the topic for discussion today is the aortic dissection, and as we know that this is one of the very uncommon, but when it is there and we rule out something for the severe chest pain or severe back pain, and sometimes the patients with coming with the acute circulatory collapse. So it becomes a red hot issue that you don't diagnose, you leave the patients without the diagnosis. So it's a big dilemma. And what percentage of patients who present, especially the patients who are the old age patients, the fragile patient, the patient who are underlying some cardiac, especially surgical intervention has gone through, or the patient who have some conditions like morphine and those, and they come across even the young age with the hypertension. Now there is another big trend for the drug intake, narcotics, the cocaine, and those they present those. So in all these subjects, when there is a severe throbbing chest pain, which is first time in life somebody come across, and very intolerable, so differentiation from the aortic dissection with the acute coronary syndrome and so on, it becomes very challenging for the emergency medicine doctor. So the why it is important, if the mortality, it depends on the malperfusion of the aortic branches that lead to the catastrophic effect, and depending on that which coronary that's involved, or the other branches of the aorta that would be involved. And then what is the most important thing in that, the high index of suspicion with using the clinical tools and some adjust labs which is available around, and depending on the clinical status, do the diagnostic medical imaging. The predisposing factors, that it could be some inflammatory conditions and the iatrogenic, like the cardiac surgery procedures, pregnancy, delivery, and the cocaine sniffing, the strenuous exercises, and the underlying connective tissue disease, so or pre-existing aortic condition. So they lead to this type of disease. Now, if you come for the classification, the two main classification, as we know, that the Stanford classification and the DBAK classification. So the Stanford classification, that we classify that in the type A and type B, and the all other section that classify type B, that come in the DBAK classifications. So it all depends that the originating, like in the type 1, that originating in the ascending aorta and propagating to the arch, and type 2 that remains only in the ascending aorta, and then type 3 that we'll discuss in other few slides about that. Now, the Society of the Vascular Surgery and Society for Thoracic Surgery, their classification is also similar to the Stanford classification. And now, what is the importance? Why this classification is important? Like the type A aortic dissection is almost twice than the type B, and the acute surgical intervention is required for type A. And every minute, every hour you spend, so you are going towards the increasing the mortality if you don't intervene in type A type of section. In the DBAK classification, that in the type 1, that involves the ascending aorta with the arch, and the descending type 2, that is the ascending aorta only, and type 3A and type 3B, depending on that if it is beyond the celiac artery in the distally or the proximal to that, and not beyond the left subclavian artery. The most common presentation that make the high index of suspicion is the chest pain and the character of chest pain. And with the clinical, and when there is a patient with severe chest pain, so always we focus that in the clinical examination, that how the pulse is and how the blood pressure, is there any deficit in the pulses, or there is the deficit in the blood pressure of the two arms or the radiofemoral, and so on. And the other finding that will go in detail further, that in the blood pressure could be hypotension or heart failure, or with the focal neurological deficits. Hypertension in 70%, it is the type B dissection, and 25 to 30% in type A. In the hypertension, that's more complicated with the type B dissections. and 5% patients that is seen usually that is with the impaired rupture and so on. The involving of the central aorta that potentially a result of aortic valve dissection, and then the disruption of the aortic wall, then it give rise to either the disruption with the pericardial fusion, and though that also give rise to the hypotension. And when there's involvement of the brachiocephalic, that give rise to the neurological features and so on. So the 90% patient who present with the acute severe chest pain and 85% onset that is the abrupt, the typical like sharp knife-like chest pain, and the medical attention that is required, that is very, that's as urgent. Pain can occur in isolation or associated with the other symptoms of the acute coronary or the heart failure and neurological features. Now, the pulse deficit, if it is the pulse deficit, it could be arm to arm or the radiofemolar, and the blood pressure variation of more than 20 mm mercury in the systolic blood pressure comparable in the arms, and that's another. If you look in the IRAD view, that the females are less involved in the pulse deficit and those, and the young patients, they have more with the pulse deficit and the blood pressure deficit as compared to the elderly. Similarly, the heart murmurs, that there's the new onset of acute aortic regurgitation, that is the very characteristic, and usually that's it's early diastolic murmur. It fades up because when there's a filling of the blood in the aorta and the ventricle that becomes equalized, so the murmur is not that intensified at that time. The focal neurological deficit that presentation can be with the earlier symptom, can be with the stroke or the altered conscious level, or it is the compression of the cervical sympathetic ganglia leading to the Horner syndrome-like pictures, the vocal cord paralysis giving to the hoarseness, or acute paraplegia depending on when there is the spinal cord ischemia. The hypotension, syncope, and the shock and initial presentation, though it is very less, but depending on if there's a cardiac tamponade, the aortic valve regurgitation, that's very severe, or there is involvement of the coronary ostium leading to myocardial ischemia or infarction, and very commonly it can lead to the hemothorax or pneumoperitoneum. The syncope, that is in 5 to 10% of patients, and that sometimes that can be with the cardiac tamponade or the brachiocephalic involvement. But the patient with IRD study, they found that the syncope is most likely in the type A, as Dr. Ghulam is 19 to 3%. And the cardiac tamponade, it's more 28 versus 8%. And those patients that with a stroke, that's 18 versus 4%, and most likely the mortality, hospital mortality is very high, 34 versus 23%. So the patient with the syncope, with the high rate of severe complication like tamponade, stroke, and the mortality, almost one half of the syncope patient that can be with the loss of consciousness, and they are more severe mortality as compared to the other patients. Now, what are the simple things which is available even in the clinics or in the small emergency room? That is the electrocardiogram. That is the study have shown that, like in one of the review of more than 4,000 patients, the 30% they were the normal ECG, and some non-specific SPT changes in 40% of the patients. And when there is the coronary involved, then depending on the coronaries, and the most common is the right coronary, as you know, so the ischemic changes that can be shown, that's in the 15%. The chest radiograph. Chest radiograph usually we do for the exclusion and to see if the finding that mimic with the aortic dissection, and especially the pneumothorax to exclude. 60 to 90% patients, they found that, like in one of the RIAD study, the 464 patients, they found that 63% patients, they had the widening of the mediastinum, and 11% without any abnormalities. So, but there is it's less sensitive as compared to the other imaging that we'll talk about now. Now, what's about the lab studies? One of the markers that is we are doing the D-dimer in many clinical conditions, that's pulmonary embolism and other inflammatory markers. So, in which the extrinsic pathway of the coagulation. So, if there is initial raise and the cutoff value of 500 milligram per ml, this is one of the very additional and with the high sensitivity when we add with the clinical diagnostic tool that we'll talk about now. And what are the diagnostic tools, the clinically, that is called the ADD risk score system, in which we talk about the classical chest pain, the pulse deficit, and chest X-ray findings. And by adding the D-dimer, that is the sensitivity is 95% with the cutoff value of 500 nanogram per ml. Now, with this diagnostic tool, with the high index of suspicion, and in which one of the study on autopsy has shown that even the patients in which these tools were not taken into consideration, or they were not added by the the features, that is the ADD with the D-dimers. So 388 patients over 60 years of survey, that 63% that they found that they couldn't be diagnosed at the aortic dissection, that the mortality results. The it's also important that to rapidly distinguish between the acute ascending and the descending, because the medical tool, right, that medical management or the acute surgical intervention, that what is required. So the clinical trial, that in one of the studies, that 250 patients, they found that 128 patients with this, the clinical trial, which we talk about, that 128 patients, they found that the dissection was positive. That's very high sensitivity. The percentage that the variation pulse in the more than 20%, and though the medial sinus widening and the aortic winding on the chest radiograph that were found. Isolated pulse and BP, that's more than 83%, they were found positive. And the presence of medial sinus in 39%, and pain alone only in 31%. So, but there is an absence of these features in 7%. So what other tool that we can do, and the patient is still there is a suspicion of the differential diagnosis of the aortic dissection. So one of the tool that is called the transesophageal echo, that can do. It can be done bedside in the emergency room, and this is a relatively safe, and especially the patients who are clinically unstable as compared to the other tests. What are the other tests that we can do? We'll just talk about that. So by doing this on the basis of the score and the high risk patients, especially with the underlying conditions, and with the physical presentation of the clinical signs of the pulse deficit and the blood pressure variation. So when we do these three, put one for each marker, and the presence of +1 marker, and with the D-dimer positive, the sensitivity is very, very high. And if it is the marker is less than 1 and the D-dimer is less than 500, so it is to exclude the aortic dissection is very, very. So we can avoid doing the further test, further imaging that we talk about. So when you have suspected the aortic dissection, and you have done the clinical features, you have done these diagnostic tools, and you have done the D-dimers, and you can proceed further, that still we need the imaging studies. Why? That we have to divide that it's ascending and ascending aorta, though sometimes the clinical picture is not very clear. So what imaging that we can proceed, and what exactly we are looking for in our study. So the different, like the MR angiography, now the CT angio, that's more commonly available, and the T that you talk about. What we're looking for, the intimal flare and the involvement of the ascending aorta, and the extent depending on the site, the brachial vessel involvement, and the aortic valve vegetation. And it gives rise to the true and the false lumen, that enlargement of the aorta, the thrombus and the false lumen, the coronary artery involvement, and the pericardial infusion. So these imagings, especially the CT angio, that is more available as compared to the others. So we can have better tools to reach on the diagnosis and to do the further clinical intervention. The aortography that is usually done when the CT angio and the MRI, that is not very conclusive. So it's not very commonly done. Because now the CT angio that's available, and it is taken more. And the aortography that's involved in the injection, that when we do the contrast and permit the identification of the site of the dissection, especially the relationship between the dissection and the major branch involvement, and the communication site between the two and the false lumen. So but the yield is really low since the CT angio is available. The differential diagnosis with the acute coronary syndrome, pulmonary embolism, spontaneous pneumothorax, aortic ridge without dissection, and some esophageal causes or the pericardial causes. So as well as ischemia and the lower extremity. So there are the different differential diagnoses, and always we used to exclude with the aortic dissection. So the management, that is the ascending, that is the it's an emergency, and the cardiac surgical intervention, and thoracic type B, that is the medical management, that is the blood pressure management. So in the medical management, that is the acute impulsive therapy that we use mainly the labetalol and metoprolol in our clinical practice, and the vasodilator, that nitroglycerin, though nitroprusside, that is also recommended, that's used widely. Now, in the ascending dissection, that the patients with even with the cardiac tamponade stroke or frank rupture, the mortality rate is as high 1 to 2% per hour after the symptom if the intervention is not done. The efficacy of intervention, if you look, that it would be the mortality, it will be from 7 to 36% with the intervention, as compared without intervention, it would be more than 50%. It just go for the medical management. Even the patient with the myocardial infarction are patients who have the pericardial effusion, and those still the surgical intervention, that it can reduce the mortality as compared with the conservative management. So there are the different options of the management we can come across. Like in one of the retrospective study of 122 patients who underwent the emergency aortic surgery in the type A, they found there's no difference in hospital mortality who not undergone the coronary angiography. So if you are suspecting the acute coronary syndrome with that, so time should not be wasted doing the coronary angiography. And because in this study, if you look at 22 versus 16%, and the coronary angiography has not much impact, it's more the wastage of time, because the time is very, very important. It's matter that how early you do the intervention. So especially we say that the aortic dissection is more with the old patients, old age patients, and they have the atherosclerotic disease as usually. So we have to do the surgical intervention as compared to do the coronary angiography at the first. The extent of open repair, different types of surgical intervention, that excision of the intimal tear, the obliteration of anterior the false lumen, the reconstruction of the aorta, repair or replacement of the aortic valve. So the different surgical procedures that can be involved in that. What is the role of endovascular repair? So open surgical intervention, endovascular repair, in which who have the ischemic complication is endovascular state that requires the graft. But there's the limited experience, or it all the center dependent, that what results they have been producing by intervening by doing the endosurgical repair. So in the type of type aortic dissection, using a stent graft to manage dissection, but it has been observed in some studies has come that by using the stent graft, there is the recurrence that I will discuss in the complication is more common as compared to the open surgical intervention. So there is another discussion that in type B, though it is mainly the medical management, that can we go for the endovascular intervention. So in some certain cases, the intervention, it can be helpful because the delay that further complication that could be avoided. So that is another area of interest, that doing the endovascular intervention in the type B also. And the intimal medical versus and the mechanical based on the observation and the randomized trial, the initial medical management for the uncomplicated, and the management for the long-term blood pressure and the surveillance series. Like in 380 patients with type B, they found that in the international study of the IRAD, 73% who were managed medically, and the hospitality was less than 10%. So the medical management is quite well accepted for the type B, and but in certain cases in which there's sort of complications like the involvement of the vessels, involvement of the end organ, so the endovascular intervention, that is another option. So the overall result of these studies that supports that the approach for the type B is the best, that's the medical management as compared to the type A, which needs the surgical intervention. And the endovascular repair that is used for the invasive alternative to open surgery for the management of type B, and the stand graft position to cover the intimal flare and the site of dissection and resulting in thrombosis of the false lumen. This is how they are doing. Now, what are the complications? The complication, that's one of the recurrent dissection. In one of the study of more than 300 patients, 3,000 patients, so they found that 204 patients, they got the recurrent aortic dissection. So the recurrence was more likely the patient who have some underlying condition, like the patient with the Marfan syndrome, the patient with the bicuspid aortic valve. So retard dissection is likely to increase the risk for the rupture and given the inherent weakness of the vessel walls. And there is a re-intervention if you are suspecting the patient with the re-intersection, so probably entograft or the endovascular involvement, you have to go as compared to just going for the medical management that here it gave a role. And the repeat surgery is required in one half of the patient in the 10 years time. So specifically who have these underlying condition of the correct diseases and who have done the previous some surgery, and there is have the the walls of the vessels, it is weak as compared to the other patients. So these are the different the resources which I've given the references. So the take-home message for the today discussion is that whenever the patients who come with the new onset of chest pain at the severe throbbing chest pain, which he hasn't come across in his life before, and we should alert, we should always have high index of suspicion for this patient that aortic dissection should be in the differential diagnosis. And we always, especially the old age patients and the patient who are having the underlying some cardiac surgical procedures, the patients who are having underlying connective tissue diseases. So with that high index of suspicion, the simple diagnostic tool that the clinical tried 1, 2, 3, that is the character of the chest pain and the clinical examination with the pulse and the blood pressure and with the chest radiograph. If the patient is unstable, to go for the transesophageal echo in the emergency room, and patient is stable, we can go for the CT angio. Like in Rashid hospital, in the resuscitation room, we have the availability of the CT scan within the RR area. And the once we have this clinical tool we have applied, we can go for the D dimers, the cutoff value more than 500, very high suspicion, more than 90% it adds. Now, if the clinical the triad, it is less than 1%, the D dimer, it is less than 500 nanogram. So the chances of aortic dissection is very less. We can it can be excluded. So probably the further imaging is not required. In other way around, we can go for the further intervention, further imaging studies, and once we diagnose clinically the patient is suspected aortic dissection, we could go for the imaging studies to see that what type of aortic dissection it is. And if type A, we go for the surgical intervention. If the type B, mostly it's the medical management, that's acute impulsive therapy and the vasodilators. But if there is involvement, start involving the end organ, and especially the patient who with underlying connective tissue malformations, so we should go for the endovascular repair as we do for the open surgical intervention or the endovascular repair in the type A. And the complications that to be avoided, early intervention, the better results, and this is how we manage the patient with the aortic dissection. Thank you very much, and thanks for being attentive.
Thank you, Ghulam, for delivering such an extraordinary presentation. Any questions from the speakers?